It's a pleasure to be here. I'm briefly introducing Dr. Friederike Holze. She will be presenting the study on LSD in patients with anxiety. She was the co-primary investigator on this study. And we will have, after the presentation of the results, the methods results, a short discussion together where you can also ask questions, and we will try to give you the answers about this study. And that will be at the end of the presentation in the last 5 minutes. So, Friede, thank you very much. And it's a pleasure to be here.
Thank you, Matthias, and hello, everyone. It's really a pleasure to be here today and to talk about this exciting new evidence of LSD and treatment for anxiety disorders. These are still preliminary data. So I'm starting off with giving you a little bit of background and to explain to you the study design. So anxiety disorders are highly prevalent, and about a third of the world's population is experiencing an episode in their lifetime. Unfortunately, current treatment methods are limited and mainly consist of antidepressants and short-acting anxiolytics. The research from the 50s through 70s has shown that LSD has beneficial effects in anxiety disorders. And with direct relation to this study, a small pilot study was published in 2014, conducted by Peter Gasser. He investigated anxiety and life-threatening illness and showed beneficial effects up to 2 months. Unfortunately, there was no valid control group. We do know a little more about psilocybin. There we have a few studies investigating depression and anxiety in patients with life-threatening cancer. And their beneficial effects up to 6 months have been reported. Unfortunately, there is no study to this day investigating psychedelics in patients with anxiety disorders that are not related to a severe somatic illness. So the goal of this study was to assess efficacy and safety of LSD therapy in patients with anxiety disorders, regardless whether they had a somatic illness or not. So for this, we conducted a double-blind, placebo-controlled 2-period crossover design. People were treated twice with 200 micrograms of LSD and twice with placebo. 200 micrograms of LSD is considered a high dose. So after screening, people were randomized either to LSD or placebo, and they were treated twice with LSD or placebo. And before the first session, measures of anxiety and depression were assessed. The same measures were assessed again between the sessions at 2 weeks, 8 weeks, and 16 weeks after the treatment. And the anxiety outcome at 16 weeks after the last treatment, measured by the State Rate Anxiety Inventory, the STAI-G, which is a well-validated tool to assess the severity of anxiety symptoms in patients, served as primary endpoint. And after these 24 weeks of the first period, patients would go into the crossover. But for the presentation today, I will focus on this part of the study, on the first period. So as mentioned before, patients with life-threatening illness and patients without life-threatening illness were included into the study. And for this, we had to adapt the inclusion criteria a little bit. In the group with patients with life-threatening illness, patients either had to have a diagnosed anxiety disorder by DSM-4 criteria or elevated anxiety scores on the STAI-G that also served as primary endpoint. In the group without life-threatening illness, the elevated anxiety scores were not sufficient, so patients had to have a diagnosed anxiety disorder according to DSM-4 criteria. In addition, patients had to be older than 25 years, and participants were allowed to have a therapy during the study, be it medicational or psychotherapy, but they were asked not to change their therapy regimen during the study. Main exclusion criteria were psychotic disorders, also in first-degree relatives, a past or present bipolar disorder, a current substance use disorder, with the exception of nicotine, and in the cancer patients, the CNS involvement. So now I switch to the results section, and I'm starting with the trial profile, just to give you a little bit an overview on the study. And essentially, before study inclusion, we pre-screened by phone or email 263 potential patients, and in the end, completing both periods, there were 37 patients left. And for the patients that were eligible for the analysis I'm talking about today, we had 42 patients. So, as mentioned before, we had a group without life-threatening illness and a group with life-threatening illness. And in the group without life-threatening illness, 100% of the patients had an anxiety disorder, which is displayed over here. And it was either generalized anxiety disorder, social phobia, or a panic disorder. And in the group with life-threatening illness, 70% of the patients had a diagnosed anxiety disorder. The other 30% would have or had an elevated anxiety score on the STAI. We also had comorbid depression patients, approximately 20% of the study population, and already 40% of the patients were treated with an antidepressant. Patients were allowed to keep their antidepressants as medications, but it was tapered off for the sessions for approximately 2 weeks. And to give you an idea about the severity of the symptoms the patients had, we had an average STAI score of a 111, and a score above 80 is considered a relevant anxiety. So patients were moderately severe in anxiety symptoms. And for the depression comorbidity, we had an average score of 19, and the score above 19 is considered as a relevant major depression. So now we come probably to the most important slide of the study. I'll explain it to you. It's the stage-right anxiety score, as mentioned before, the primary outcome. And here we have the first period, 24 weeks. And in black, we have the placebo patients, and in white, the LSD group. And the dotted lines show the treatment sessions at 2 and 8 weeks. So these are change from baseline scores, and we do see rapid, long-lasting, and significant reductions in anxiety up to 16 weeks post-treatment. And 65% of the patients in the LSD group versus only 9% in the placebo group showed a significant clinical response. And this is a really important finding because it's essentially the first modern study with a psychedelic that shows long-lasting effects up to 16 weeks directly compared with a placebo. And we can not only show this for anxiety symptoms, but also for the comorbid depressive symptoms. So the Hamilton Depression Scale, which is an investigator-rated scale, shows effects up to 16 weeks post-treatment. And we can also show that on the Beck Depression Inventory, which is a self-rating scale for depression symptoms. And 56% in the group, in the LSD-treated group, showed a clinical response on depression symptoms. That means they had a Hamilton score below 10, which means they were essentially at some point during the study in remission. And we also linked the primary endpoint at 16 weeks to the acute effects patients had during the study. And the positive effects and mystical experiences were strongly linked with the long-term therapeutic outcome, whereas the negative effects that were acutely experienced remained neutral in regard to therapy outcome. And this is a nice finding because with this we essentially do have a biomarker just by 2 simple questionnaires assessing positive effects and mystical experiences. This finding is not entirely new. It has already been shown for psilocybin and anxiety and depression. So therefore, this finding has a strong confirmatory aspect for the whole class of psychedelics. And just wanted to lose some words on the safety as well. We have to distinguish between treatment-related adverse events and non-treatment-related adverse events here. Treatment-related adverse events were, for example, untoward effects during the treatment sessions. We had some patients experiences nausea, anxiety, and headaches, but the numbers were very low. And we had one serious event of a patient who experienced acute transient anxiety and delusions during an LSD session. The patient was treated with benzodiazepine and olanzapine, completely recovered, and as a conclusion of this, we reduced the LSD in the second session to 100 microgram. Overall, we had no recorded instances of acute suicidality. And regarding the non-treatment related adverse events, we had a total of 229 during the whole study. The most frequent were headaches, nausea, dizziness, difficulty to concentrate, common cold, insomnia, all things you would expect from a psychiatric population. And we had an overall of 8 additional serious adverse events, but they were mostly due to the underlying illness in the cancer patients. So, LSD produced fast, long-lasting reductions in anxiety and depressions up to 16 weeks post-treatment. And again, this is the first modern study showing significantly lasting effects up to 16 weeks directly compared with a placebo. We did see that acute positive effects and mystical experiences are significantly and strongly correlated with long-term therapeutic outcomes. And again, this is a nice biomarker to have for the therapeutic outcome. And overall, LSD was safe and well tolerated. Thank you for your attention. I have especially to thank Peter Gasser and the whole study team, Peter who acted as PI on the study, and the Swiss Medical Society for Psychedelic Therapy who funded the study, and MindMed for the support.
Thank you, Friede, for this very precise, clear presentation. And it's a pleasure that we have about 10 minutes to discuss the findings and take questions from you. I guess this was the first modern, well placebo-controlled study with LSD, but you all know that there is more data on psilocybin from several excellently conducted studies in patients, not exactly the same population, but we think that all together now we have quite a lot of interesting clinical data. It's not so important to us whether this is LSD or psilocybin, as we see very, very similar results. We can essentially confirm with this study what has been seen with psilocybin. A strength of this data is certainly that we have a control condition up to 4 months after the treatment, while with most other studies that we have so far, typically the placebo control was present only for 5 or 6 weeks. We have more lasting effects that have been documented for LSD and psilocybin, but typically there was no placebo control at 1 year or something, like what was used for long-term outcomes. So we start taking questions. Maybe we'll have to repeat them if we cannot hear them. Maybe there is a mic, I'm not sure. Otherwise, we'll just repeat the questions from the audience. David, I have to take you first, as you are the PI of many of the important studies on psilocybin.
Well done. I mean, just two questions of sort of mechanism. Why did you wait for 5 weeks to get your first data point? Because you might have imagined that you'd have the effect within 1 day, like with other psychedelics.
So
we have a microphone.
The question was, why did we wait for 5 weeks? So the first treatment with LSD Then we had about 2 to 3 weeks after that the second treatment with LSD, and the first outcome was measured 2 weeks after the second treatment. And I do agree that it could have been interesting to have a readout, maybe even the next day. So in this study, there's many different ways how you can do this, but you could say 2 weeks after the second treatment we had.
That begs the question of why did you need a second treatment?
Whether you need one or two, the question is, do we need one session or 2 sessions? Also, it's really discussed because you can do, maybe one session was enough. We cannot tell whether the second session here added any benefits or not. From the limited use program in Switzerland, where up to probably hundreds of patients have already been treated, not within studies, we think that more than one treatment is beneficial in the majority of patients. And actually we see this also here a little bit, that you have a response after 2 weeks, but then it kind of diminishes a little bit, and after like 4 months, not every patient will be still fully treated, of course. Yes. Do we need one treatment or more? We don't know it. I don't know whether you know it.
Yeah. Well, we know with psilocybin in depression, one treatment works, but 2 treatments may give a more enduring effect. Just the last question from me. So you had 45% coming off SSRIs.
40%.
Was there a difference in outcome between those who had come off and those who hadn't? Because that's a kind of theoretically interesting question.
Yes, so similar to the studies that you conducted with psilocybin, and you have addressed this, whether there is a difference in the patients stopping the SSRI or staying on the SSRI. So first of all the patients were kept on the medication, but we only stopped the antidepressant during the treatment, meaning 2 weeks before we gave the LSD, but then typically a few days later they were put back on the drugs, on the medication. So it was in a way an add-on that we did. Do we know already whether there was a difference between the patients that had an SSRI at all in this study, or who haven't? I don't think so.
No,
right?
I don't think we have conducted this subgroup analysis yet.
So subgroup analysis, these are all important questions, but it is a risk to do too many subgroup analyses because the study may not be powered for this. Our assumption is that there is no difference, but we'll see. So for psilocybin, for those, because this is an important topic, does the antidepressant interact with the psychedelic? We believe no. If you give an SSRI, even during the psilocybin session, the effects will be the same. This has been shown in healthy subjects and now also in a smaller study in patients. But it still needs further investigation, but we are confident that most likely in the future you can do the psychedelic sessions just on top of any other treatment. You don't have to go into withdrawal from the antidepressants, most likely, but we will have to study this further, and David will, I'm sure. Other questions from others? We will have to limit ourselves, or otherwise the organizer can stop us from talking, but we have to... Yeah.
Hi, thanks for the presentation. So we've seen similar results from psilocybin studies. Do you have any insights on the difference in the phenomenology that led to the results, or was that not part of the scope?
So I may not have understood you correctly. Is there a difference between psilocybin and LSD?
Right, but in their method of action,
no,
and in the types of experiences that they had.
No, the two are the same. Okay. Brief answer. Well, the duration of the substances the duration of the effects are different. LSD lasts 11 hours, and psilocybin 6. And for all others, we can take questions also in the breaks, of course.
Hi.
One more.
Thanks for the study. It's great work. My question was about, I know one of the challenges with psychedelic research is the actual placebo itself, because people know when they're having the treatment because it's such an obvious physical experience. And so if the placebo is an experience where nothing happens, then it might not be an adequate control. And I know that's one of the challenges with psychedelics. So was that something that was thought about in the results, where there still could be a placebo effect just because people know they've had the experience?
So this is being discussed. What is the correct placebo in such studies? Here we had an inert placebo. However, I mean inert. These guys, these patients were spending 12 hours with a highly experienced therapist. So this effect is still present. You have the psychotherapy in both sessions, and you can imagine the people on placebo, they will be talking to their psychiatrist more than the patients on LSD who are basically experiencing what they are experiencing. And so the placebo was the therapist, you could argue. Yes, and of course there's a placebo response, but it was not an active placebo, and subjects can distinguish between LSD and a non-active placebo in most cases. Yes. I guess we have one more. Yeah.
Over here. Terrific results. Congratulations. I just wanted to ask a question about dosage selection, and you mentioned 200 mics for each patient. Why did you set it at that level, and also was it varied by body weight? Because I think relative to the dosages in psilocybin, 200 is quite a bit stronger on a relative basis. So what gave you the conviction to go with 200?
So if I may summarize what I understood, why did we use 200 micrograms of LSD compared to what's being used as a dose in psilocybin? 200 micrograms of LSD base is equivalent to 40 milligrams of psilocybin, and the typical doses in clinical trials so far were 25, 30, I think, maybe at most in the trials. So this is probably the first study using a higher or high dose of a psychedelic. And we believe this is not even needed. The tolerability may go up if we go down to a dose of 150 micrograms of LSD. That's the short answer.
Was it varied by body weight?
It's not dosed by body weight. That's not, let's say, there's no study indicating that this is needed with psychedelics. On the contrary, there is no body weight and or let's say dosing by body weight is not a benefit compared to absolute doses. There is no link of the effects with the body weight for LSD and psilocybin. For MDMA, yes.
Thank you.
Let's stop it here, maybe, or another, I don't know.
We can tell that everyone is super interested in this topic, so we can keep going with questions, if that suits. Anyone else?
In front. And as said, we are very happy to discuss the results further in the breaks.
I mean, this is just back to the placebo. I mean, in what way can you meaningfully describe the trial as a double-blinded study if it wasn't a study in which participants could...
Yes, so can you label it double-blind if it's unblinded by the effects of the psychedelic? That is the case for, I would say, any study with a psychedelic. Even if you include an active placebo, it will mostly unblind. The only approach that you could take is that you have different doses of psychedelics, and people may not be able to distinguish 200 from 100 or from 50 micrograms of LSD. That's an approach. Otherwise, in most cases, an active placebo will unblind, even an active. Well, anyway, the design is double-blind, but I fully agree that this is unblinding itself. If you take 200 micrograms of LSD, almost everybody will realize. We had one patient not realize, thinking he was on placebo while he was on 200 micrograms of LSD. David, I think, indeed. So I think we have to stop, do we?
This will now be our final question.
This is the final. I don't know whether it's David or the lady.
You mentioned that the participants had 12 hours of experience therapy, or they were with an experienced therapist. Could you explain what that kind of therapy entailed, or how that therapy was carried out?
That's a question that would need a long answer, but let's just say all the therapists doing this trial were also involved in limited use therapy in Switzerland. That means they have years of experience with psychedelic, specifically psychedelic assisted psychotherapy, but there was no specific psychotherapy that was used here. And as you know, during the sessions, there is no psychotherapy. It's just sitting.
And maybe we did not have a standardized protocol for the sessions. it was a one-on-one setting, and every therapist had to decide how he would go with the patient.
Thank you very much, and it's a pleasure to see all this interest in the trial and in the field.